Hello, my name is Lauren Brown, and I am an Associate Professor of Pediatrics and Emergency Medicine at the Medical College of Wisconsin in Milwaukee, Wisconsin. I am pleased to share today with you some take-home points for prehospital pain management in children and a brief summary of the research into prehospital management of pain in children. The research we will discuss today was supported by the United States Health Resources and Services Administration through an Emergency Medical Services for Children Targeted Issues Grant. The information, content, and conclusions shared in this presentation are those of the authors and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, Health and Human Services, or the United States government. Our objectives for today's discussion will be as follows. First, we will review current evidence-based protocols for prehospital pain management. Then we will describe a recent study that evaluated the impact of these protocols when placed into clinical practice on the pain management of injured children. Finally, we will conclude the discussion today by reviewing the essential need for a better understanding of the barriers encountered by EMS providers that inhibit the appropriate management of pain in children. By way of introduction, prehospital recognition and management of pain is a stated clinical priority by many professional organizations. Unfortunately, children are at higher risk for poor prehospital pain management when compared to adults. Thankfully, national evidence-based prehospital pain management guidelines exist to help guide EMS medical leadership in developing evidence-based protocols and to assist EMS providers in the appropriate management of pain. An example of such a protocol is an evidence-based guideline for prehospital analgesia and trauma published by Dr. Marianne Gaucher-Hill and her colleagues in Prehospital Emergency Care in 2014. Though variations of this protocol exist, the current protocols share many of the same evidence-based suggestion elements. It will be helpful to review these evidence-based suggestions. The first part of this evidence-based guideline recommends that pain assessment be part of the general patient care in both children and adults, and not a separate skill in and of itself. Further, all patients should be considered as candidates for pain management regardless of transport interval. The time required to transport the patient to definitive care should not be allowed to influence whether or not pain management interventions are utilized in the prehospital setting. Second, the use of age-appropriate pain scales to assess pain is recommended. Age-appropriate pain scales are important because a pain scale may not accurately reflect the severity of a patient's pain if it is not consistent with the child's developmental ability to respond. For example, children younger than 4 years lack the skills to assign a number to their pain severity as is done with older children and adults, but instead should be assessed with a behavioral observation scale such as the FLAC. Children 4 to 12 years old begin to have skills that allow them to rate their pain accurately with the use of such devices as variation in colors or pictures. The number-based pain scales may reliably be used in children older than 12. When a child is assessed to be in moderate to severe pain, opioid analgesia is recommended. There is strong evidence to recommend the use of either intravenous or intraosseous morphine at a dose of 0.1 milligrams per kilogram, or intravenous, intraosseous, or intranasal fentanyl at a dose of 1 microgram per kilogram for children whose pain scale score is greater than 4. Also important in these clinical guidelines are the adverse effects and relative contraindications for the use of opioids. These include the risk of sedation, hypotension, and hypoxemia, as well as the contraindications of known allergy to opioid medications or conditions that would prevent safe administration of opioids. Finally, it is important to remember that after opioid analgesia has been administered, it is necessary to reassess the patient every 5 minutes to ensure that pain severity is improving. If significant pain still exists 5 minutes after the initial dose of opioid analgesia, the recommendations are to redose opioid medication at half the original dose. Despite these evidence-based guidelines being well publicized and frequently used in clinical practice, it is not known how implementation of these guidelines affects the use of prehospital opioid analgesia in injured children. We set out to determine the changes in prehospital pain management before and after implementation of these guidelines. Specifically, we were interested in how often pain was assessed before and after, and how often opioid analgesia was given before and after implementation of these guidelines. We looked at the EMS records of 3 participating agencies before and after their most recent change in their pain management protocols. Specifically, we looked at patients who were less than 18 years of age and encountered EMS with an injury-related prehospital primary impression within 18 months before and 18 months after the most recent pain management protocol change. As you may expect, the pain management protocols in practice by each of our 3 agencies were not entirely consistent with each other. This table shows the recommended evidence-based guideline elements and indicates whether or not they were included before or after each agency's most recent protocol change. You can see, for instance, that assessing pain as part of a general care was included both before and after the protocol change for agencies B and C, but was not included either before or after protocol change for agency A. Here we highlight the best practice elements that did change with the most recent pain management protocol revisions. In agency C, an age-appropriate pain scale for children less than 4 years of age was added. For agency B, an age-appropriate pain scale for children 4 to 12 years of age was added. The minimum age of opioid administration without online medical direction was reduced from 5 years to 1 year, and the dosage of fentanyl was increased to be in line with current recommendations. Finally, agency C implemented the protocolized use of non-pharmacologic interventions, such as splinting an injured extremity, application of cold or ice, or distraction techniques. What did we find? When we looked at the percentage of children in moderate to severe pain who received pre-hospital opioids before and after the protocol change, we found no significant difference in the rates of opioid analgesia in the sites individually or collectively. Agency A, prior to protocol change, treated 15.5% of their patients with opioid analgesia. After the change, it was 14.2%. Agency B went from 3% to 1.9%. And agency C went from 22.1% to 25.9% of their patients receiving pre-hospital opioid analgesia. As you can see, with rates of 15.5% and 14.3% before and after protocol change, the three sites collectively showed no statistical significant difference in the percentage of injured children receiving opioid analgesia after protocol changes. What does this mean? It means that many injured children in moderate to severe pain do not receive opioid analgesia during pre-hospital care. The addition of evidence-based elements to EMS protocols in these three sites did not improve the rate of pre-hospital opioid analgesia to children in moderate to severe pain. It would seem that implementation of evidence-based guidelines alone is not sufficient to improve the appropriate use of opioid analgesia for injured children with pain, and that other barriers to the appropriate pre-hospital pain management of pain must exist. To better understand how to improve pain management practices in the pre-hospital setting, further work must be done to understand these barriers and how to best address them. Thank you for your attention and your time. If you should desire the full text copy of this research study, it can be found in the journal Pediatric Emergency Care on pages 759 to 767 of volume 20, published in 2016. Should you have any questions for the authors, please do not hesitate to email the primary author at lbrowne@mcw.edu. Thank you very much.